you. Thank you so much for the introduction. So my name is Pitcha Champupong, and I'm a fellow. Actually, I'm doing my second fellowship in autonomic disorder. My first fellowship was in neuromuscular disorder. And this study was work that was done during my first fellowship. So let me share my PowerPoint and we can go into the talk. Can you see the PowerPoint okay?
Yes.
Okay. So the title of our talk is Utility of Carpal Tunnel Release and Ulnar Decompression in CMT1A and HNPP. So CMT1A stands for Charcot-Marie-Tooth 1A, HNPP is hereditary neuropathy and pressure palsies. And I'm the first author here. Dr. Klein is the senior author who is here with us to correct me if I'm wrong. All right, so let's move on. I don't have any relevant disclosure. So the outline of the talk today is going to talk about carpal tunnel syndrome, cubital tunnel syndrome, what they are. We're going to talk about PMP22 mutation and how it's related to CMT1A and HNPP. We talk about the surgical outcomes of nerve decompression surgeries for a patient with HNPP and CMT1A. And also we're going to tell you how we identify appropriate candidates for the surgeries. First, what is carpal tunnel syndrome? So carpal tunnel syndrome is characterized by pain and numbness of the hands due to excessive pressure on the median nerve at the wrist. So it can be treated non-surgically with sprinting and steroid injection, and in severe cases, it's treated with carpal tunnel release surgery with success rate of up to 80%. Without appropriate treatment, carpal tunnel syndrome can lead to nerve damage, permanent muscle atrophy, and loss of hand function. And it affects about 1 to 5% of general population and is a leading cause of work disability. Carpal tunnel syndrome causes about 1 to 2 billion in annual direct costs in the United States. There are two main pathomechanisms of carpal tunnel syndrome. The more common one is the first one, which is external compression from swelling or thickening of soft connective tissue surrounding the median nerve within the carpal tunnel. So if you look at the picture in the bottom left here, that shows the cross section of carpal tunnel. As you can imagine, if these tendons swelling up or the ligament is swollen or these bones had arthritis and swell, then it can compress on the nerve. Less frequently, carpal tunnel syndrome is caused by a problem within the nerve itself. So either nerve dysfunction, such as the tumor of the nerve, or from the nerve being having increased susceptibility to compression. So several risk factors have been linked to carpal tunnel syndrome. So medical conditions such as diabetes can cause nerve damage and also swelling in the carpal tunnel in the wrist. Rheumatoid arthritis can cause tenosynovitis, which is inflammation of the tendons and then compress on the median nerve. And other diseases such as thyroid acromegaly or pregnancy can cause carpal tunnel. Some activities and occupations have been linked to carpal tunnel, occupation requiring repetitive wrist movement. But the data is still controversial because there were twin studies that suggest that genetic has more influence on carpal tunnel syndrome than the environmental factors. And the last one is genetic. So mutation in genes like TTR or PMP22 have been linked to carpal tunnel syndrome. What about cubital tunnel syndrome? So cubital tunnel is compression of the ulnar nerve at the elbow. The ulnar nerve travels through this a tunnel called cubital tunnel at the elbow. The roof of the tunnel is aponeurosis, or this thin fascia connecting the two heads of this muscle, which is the flexor carpi ulnaris muscle. And the floor of the cubital tunnel is the medial elbow ligaments, or this one here. So this is the most common place where the ulnar nerve is entrapped at the elbow, especially when the elbow is in flexion position. because when you flex the elbow, the distance between this bone called olecranon and the medial epicondyle increases, and then that results in compression of the nerve. So there are several techniques for decompressing ulnar nerve as well. Some surgeons do open surgery, some do minimal invasive endoscopic approaches. And in some cases, once the nerve is decompressed, they also move the nerve out of the cubital tunnel to prevent further compression. And that's called transposition surgery. Surgical decompression is also proved to be effective, but it can cause in some cases, it can cause complications, and recurrence of the symptoms is pretty common. So now let's talk about the PMP22 gene and the diseases. So PMP22, 22 is the weight of the protein. So it's a 22 kilodalton protein produced by Schwann cells that are expressed in compact myelin of the peripheral nervous system. So if you think of a nerve as electric wires, then the wire itself is axon, and then the myelin is the insulation of the wire. So mutation in this gene can cause two different diseases. If the genes is duplicated, then it can cause Charcot-Marie-Tooth 1A or CMT 1A. If the gene is deleted, then it causes a different disease called HNPP. So in CMT1A, you can see that this is the picture of nerve biopsy. So in CMT1A is the top picture here. You can see that the mutation causes the Schwann cells to extend their membrane around the nerve axon, but then the myelin is not as compacted as it should be, and it forms into this structure, which we call onion bulbs. If we look at the nerve itself, then you see that the nerve is enlarged because of all these onion bulbs within the nerve. So normal size of the nerve would be the top one here. If there's this onion bulb, then the nerve is enlarged. Now, the two picture below is this picture of HNPP, and this mutation is a loss of function mutation, and it causes the myelin to form into this sausage-like structure, or what we call tomacula. So among all inherited neurologic disease, CMT1A and HNPP are probably the most common genetic neuropathy. The reported prevalence from population-based studies in CMT1A is as high as 1 in 3,800 people. And then in HNPP, there's a large discrepancy between prevalence from recent newborn screening data, which is 4 times higher than population-based studies, which suggests that this condition is probably very underdiagnosed. Even though the two diseases are caused by the same mutations, the clinical presentations are very different. CMT1A usually present with progressive numbness, deformity of the feet. Patients usually have family history. And then when we look at the nerve conduction study, then the conduction velocity is very slow. While patients with HNPP, their nerves are more susceptible to compression. So they usually present with multiple neuropathies at compression sites, most commonly median nerve and ulnar nerve. But these episodes are usually a transient episodes with spontaneous resolution. So if they wait out about a few months, then the symptoms tend to improve by themselves. And HNPP is usually frequently underdiagnosed because there's no family history. So carpal tunnel syndrome and cubital tunnel syndrome is much more common in patients with HNPP and CMT1A compared to the general population, and these conditions result in poor hand function, contribute to reduced quality of life, as we mentioned. So how do we diagnose carpal tunnel syndrome and cubital tunnel syndrome in patients who already have underlying neuropathy? So usually carpal tunnel syndrome is a clinical diagnosis, which means you just take the history, do the exam, and then you can make the diagnosis, no tests are needed. However, it's not always that simple in a patient who already had numbness in the fingers. So the distribution of the symptoms are important. The pain or numbness in CMT1A neuropathy usually affect all fingers equally, while if the symptoms are more prominent in the first 3 fingers, that can be suggestive of carpal tunnel syndrome. Or if the symptoms are more prominent in the 4th and 5th fingers, then it can be suggestive of ulnar neuropathy or cubital tunnel syndrome. However, that's not the only thing we look for. The other important part is that there's a sign called Tinel sign, which means that the symptoms are provoked by tapping at the compression site. So if you tap at the wrist and then the symptoms is aggravated, so that's more suggestive of carpal tunnel syndrome. Or if you tap at the elbow and the symptoms are more aggravated. And these are called positive Tinel sign. And this sign usually mimics patients' reported history of symptoms being provoked by activities with repetitive movement of the wrist, such as like playing guitar and then these 3 fingers become numb, or compression at the wrist, such as carrying groceries on your wrist, or unintentional flexion of the wrist or the elbow at nighttime, like you wake up having numb fingers. So in HNPP, clinical diagnosis may get even trickier because HNPP patient can present with transient episodes of median and ulnar neuropathy at compression sites. So in our study, we only included HNPP patients who had symptoms persisted for more than 6 months. So how do we measure severity of carpal tunnel syndrome? So it can be measured by several scales. One of the scales that are used most commonly is called SSS, or Symptom Severity Scale. So as you can see, many questions on the scale focus on symptoms during nighttime, which are more specific to the compression physiology, because at night, you don't know if you flex your wrist or flex your elbow, and then symptoms usually come on during the night. So when clinical history is not so straightforward, then clinicians usually rely on additional testing. And we typically use one of the 2 or both, which is nerve conduction study or neuromuscular ultrasound. So, and we're gonna go through both of them and see how the interpretation of these nerves are not so straightforward in patients with CMT either. So for carpal tunnel, like one can do internal comparison studies. So comparing median to ulnar nerve. If you look at this picture here, if you stimulate the median and stimulate the ulnar nerve and recording at the same distance, you can compare how fast the nerve transmits through each nerve. If the median is lower, then maybe the patient has carpal tunnel syndrome. So this works for patients with HNPP, but not in CMT1A, because CMT1A nerve can be so severe that the response is all gone, is absent, so there's nothing to compare. Similarly, if you look at cubital tunnel, we usually try to find this focal slowing at the elbow, but in CMT1A patients, sometimes those signals are already gone, so that can't be detected. So what else can we do? What about ultrasound? So ultrasound in general, repetitive compression of the nerve resulting in swelling of the nerve at the compression site. So with ultrasound, the cross-sectional area or CSA, circumferential surface area or CSA can be measured. So we can identify the beaded nerve and measure the size of it. And we usually do it at 2 sites at the wrist and compared to the forearm. If the nerve is enlarged at the wrist, a normal size in the forearm, then it's suggestive of carpal tunnel syndrome. So we use 2 cutoff. If the size is more than 12 millimeter at the wrist, then it's big. Or we compare between forearm and wrist and do the ratio out of the 2. If the ratio is more than 2, then that means that the median nerve might be compressed. And in cubital tunnel syndrome, we just look at the ulnar nerve at the elbow and see how big it is. But can we apply these ultrasound parameters in patients who already have neuropathy? So our study also looked at this, and this is the result of our patients. So when we look at the HNPP patient, the ultrasound does detect swelling of the nerve. So if you look here in blue, the nerve is enlarged in the wrist, but not in the forearm. And the ulnar nerve is enlarged in the cubital tunnel, but not at other sites. But in CMT1A, ultrasound doesn't seem to help either because the nerves are all enlarged along the course throughout the arm. There's no additional enlargement at the compression site. So in summary, ultrasound probably detect nerve compression in HNPP, but probably not in CMT1A. So what about previous studies on surgeries in these patients? So there was only one large study that previously evaluated treatment outcome of patients with inherited neuropathies and carpal tunnel syndrome. And in that study, they found that CMT1A patients who used splint or underwent carpal tunnel surgery did well after surgery. And they had reduction in SSS score. However, only one HNPP patient underwent surgery in that cohort, so they didn't have enough data to draw any conclusion. There had been a few other case reports reporting role of carpal tunnel release in HNPP patients. Some of them say that decompressive surgery can increase the risk of secondary nerve damage in HNPP, so it do harm. But the other study actually showed that the surgery could help improve clinical symptoms as well as nerve conduction finding. So because of the lack of data, we then decided to look at our Mayo Clinic cohort. So we searched for all the patients who had mutation in PMP22 genes during the year of 1999 to 2020, and we found 112 patients. 60 patients with HNPP and 52 patients with CMT1A. The two bar graphs below here demonstrated that about half of HNPP patients had clinical diagnosis of CTS or carpal tunnel syndrome and cubital tunnel syndrome, which are more common than CMT1A, and both are more common than general population. So among these, 15 underwent carpal tunnel surgeries, and then 6 underwent cubital tunnel surgeries. So you can see that more than half of the patients who had clinical symptoms of carpal tunnel and cubital tunnel syndrome did not undergo surgery. And when we look at the chart, the result for them not going to surgery can be concern that surgery might not help because they already have underlying neuropathy, or fear that surgery might worsen the course. And some of them had milder symptoms and improved with just splinting. So these are the results of our study. So post-surgical improvement in our study is measured by reduced numbness, pain resolution, improvement in grip strength, restoration of ability to perform daily activities, and also improvement in nerve conduction study parameters. And the improvement is actually sustained with no recurrence of symptoms in the period of 62 months. So we found that the success rate of carpal tunnel release in CMT1A was similar to general population, which is 80%. Improved after surgery. In contrast, the success rate of surgery in HNPP patient is a little less than general population. So because of the poorer outcome, we then look further into HNPP patient to see which patient would benefit from surgery. And to our surprise, when we look at the enlargement of the nerve on ultrasound, that did not reliably predict successful surgical outcomes. So even though some patients had big nerves at the wrist, when the nerve is decompressed, they still don't improve. But we found that the only predictor that can predict good surgical outcome is if the patient still complain of activity-provoked symptoms. So to summarize the carpal tunnel surgery, we think carpal tunnel surgery is likely successful in CMT1A. The success rate is about the same as patient who didn't have neuropathy. But for HNPP patient, it can still be useful, but the symptoms has to persist for several months, but it's still need to be activity provoked, which means when you flex the wrist, when you do repetitive movement of the wrist, is aggravate the symptoms. If that component is lacking, we're not sure if surgery is gonna help. Now, what about cubital tunnel release? So despite our small number of patients, the result shows significant difference between CMT1A and an HNPP patient. So we had one CMT1A patient who underwent cubital tunnel, and that patient improved significantly. The numbness improved, the hand strength improved after surgery. While in HNPP, minority of patients improved with surgery, 2 patients actually did worse after surgery. They had worse pain, worse numbness, and then when we did nerve conduction, and the numbers also look worse. So in cubital tunnel, in CMT1A could be successful, but we are not sure because the number is small. But in HNPP, the surgery can worsen the course. So why are the 2 diseases so different in terms of post-surgical outcome? So we think that in patients with CMT1A, carpal tunnel syndrome is actually caused by structural compression of the hypertrophic nerve, taking up the space in the carpal tunnel. So as you can see in the biopsy pictures here, you can see a lot of onion bulbs around the nerve. These onion bulbs actually result in enlargement of the nerve fascicles, like I showed you before, which then results in the large nerve that we see on ultrasound. And then this large nerve is being compressed in the carpal tunnel. So performing release surgery should help. Now, the patient with HNPP, their nerve is not enlarged, but the tomaculi or the sausage-like structure here actually impair the ability of nerve to transmit the signal along its course. So it's physiologically compromised. So it's not structurally compromised. So surgical release might not help. However, based on our report, there are probably some of them who also have structural component, and that can be determined by if the symptoms are activity provoked or not. So if it's activity provoking, then it's probably compression physiology and surgery might be considered. So to conclude, in CMT1A patients, so diagnosis of carpal tunnel and cubital tunnel syndrome are gonna have to be largely based on history and exam. Nerve conduction study and ultrasound do not add much to the diagnosis, but surgical outcomes are actually good and similar to general population. For NPP patient, nerve conduction study and ultrasound can help detect those compressive nerves, but it do not translate to the same good surgical outcomes. Because actually, you have to actually go back to the history and based on the activity provoking symptoms to determine the outcome. And then if the patient has ulnar neuropathy, then release should be very carefully considered because it can become harmful. I have this extra slide here because HNPP nerves are so physiologically fragile. So different surgical technique might play some role in surgical outcomes. So the picture shown here is the current conventional surgery technique, which is the open surgery. So they just cut your wrist open and then decompress, or they can do endoscopic release, put the camera in. But at Mayo Clinic, we are developing a new technique, and this is developed by Dr. Shin and Dr. Brow. And this technique uses ultrasound guided They guide the needle through the carpal tunnel with ultrasound, and then they put the cutting thread inserted through the needle and then create a loop. Then under direct visualization with ultrasound, the thread is pulled back and forth. So it's pulled back and forth to cut the ligament. So this technique is aimed to be the least invasive, but the risk of median nerve surgery we need to be further investigated in this group of patients. But we are offering this at Mayo Clinic. That's all we have, and now I can take some questions.
Wonderful. I will, let's see, let's go back to, is it okay to stop sharing, Dr. Champupong? And then we can see who has questions. So I'm going to go to gallery view. And what we'll do, a couple things, everyone. I meant to say this at the beginning. Obviously, the doctors cannot answer personal medical questions here tonight on the Zoom. So keep that in mind. But they will do their best. So if you have questions, if you want to physically raise your hand or use the Zoom hand indicator. So Sarah Kesty, thank you for being with us. Sarah's on our advisory board. Good to see you.
Hey, you too. I'll put my hand down in a sec. I had a tendon repair and I was wondering if the doctors have input on the tendon shortening. It is stuck like this. I severed my flexor tendon and I cannot get it beyond this stretch. And I'm just wondering if it was an accident that got me in this situation, but does CMT interact with my healing? Because my hand surgeon is stumped.
Maybe I can take that one. That's sort of a carpentry, not a wiring question you raised, because it's the cable, not the wire. So we don't have any reason to think in CMT that the cable's defective. So it could relate to other things, which you need to review with your doctor. So poor tendon recoveries can sometimes relate to other medical illnesses like mild diabetes, thyroid disease. But certainly any tendon injuries can result in a secondary injury to the median nerve through the wrist. So that is the second group of disorders that Dr. Champupong discussed, which are the external compression mechanisms, like we see with arthritis, like we see with tendonitis, where the tendon itself gets so big that it can push on the nerve. And you may be slightly more susceptible to nerve compression from a tendon injury than the general population. And I think that's one of the points I wanted to emphasize from Dr. Champupong's talk, is that in the earlier study from Rochester by Dr. Herman, they found about 30% of their cohort had carpal tunnel syndrome. But what our study showed was that up to 50% of patients had carpal tunnel. So just by a flip of a coin, not knowing anything else about your medical history, you may have both a tendon issue and carpal tunnel. So I would just raise that issue with your doctor.
I appreciate it. Thanks. And then you mentioned other metabolic things. I do have osteoporosis, but I feel like that's just bone stuff. It wouldn't really play in, right?
Well, I think both rheumatoid and osteo can give you structural narrowing at the wrist. And so that's one of the other things that we didn't talk about, which is that the ultrasound can not only tell you about the anatomy of the nerve, but it also can provide insight about tendon swelling. You can sometimes see really gross structural bony abnormalities. And sometimes we'll even see an aberrant vessel, which we want to alert the surgeons to, because that can lead to a complication during surgery. And Dr. Champupong's very modest, but she actually worked at Case Western before she came to Mayo, before her 2 fellowships now on carpal tunnel in the general population. And she might want to have a word about ultrasound and its value in structural as well as primary nerve issues.
I can add a little bit to your question. So the tendon and bone issues can affect the nerve when they are close to each other. So if there's swelling, if there's inflammation, then it can affect the nerve. However, the symptoms, when the nerve is impaired, then it usually results in weakness and numbness. So if you can't move
Mhm.
your thumb, it's probably because the muscle is weak. But if you can't move your thumb because it's stuck, then it's more
Mhm.
of a wiring tendons issue rather than the nerve tissue itself, if that makes any sense.
It totally makes sense. Yeah. And I've been getting a little bit of, well, maybe it's your CMT from my doctor. And I'm like, I want to rule this out, but it was absolutely perfect timing. And I'm so appreciative of your information tonight. It was just on a whim that I had emailed CMTA last night. And then this was today.
Yeah, I think the important point for everybody to realize is that people with CMT do not exist in a vacuum. So they can develop other problems like diabetes or thyroid or other risk factors that add additional consideration in the approach. So that's very important to review kind of comprehensively your medical health.
Absolutely. Thank you.
Then-
Norm.
Oh, sorry.
Sorry. Go ahead, Dr. Champupong.
I think Dr. Klein wanted me to share another benefit from doing an ultrasound. So even though I said if you have CMT, ultrasound might not help much in terms of diagnosing carpal tunnel, but it actually can help detect structural defects in the wrist if you have one. So we can see the nerve being big, but if we put the ultrasound probe on, sometimes we can detect swelling of the tendons compressing on the nerve. Sometimes we ask you to move the wrist and then we can see that it's being squished by an artery or something that's next to it. So that's the additional benefit from the ultrasound. And if you are right-handed and your symptoms occurred in the left hand, then you should probably convince your doctor to try to ultrasound or image it, because it's not common to have it on the non-dominant hand first.
Interesting. Thank you.
Thank you. Thank you so much.
Hi, I'm sorry I came in late. I couldn't help it, but I've been having problems. I've been diagnosed with CMT and peripheral neuropathy about 25 years ago, and I'm a Kaiser patient, and my hands are getting really bad, and they're having a trouble being able to help me. They did the surgery where they took the tendons from my arm and wrapped them around different ways and stuff in an effort to cup my hands so I could maybe grip things better. But they ended up making it worse. See, with these two fingers here, I can't move them. Is there any, this sounds like a stupid question, but is there any place I could go that really knows CMT that I can maybe get them to refer me to? Because it seems like every month this just gets worse and worse. I can barely do or hold on to anything anymore.
Yeah, I just looking at your hand there, I think there probably is more than one thing going on. Are you able to flatten it? Like if you put your hand on a, so that's back
No.
kind of, it's a deja vu of the first question, because
Yeah.
now you're developing a structural shortening of the tendon so that it's unable, just from the cable itself, to be extended. So there, are a lot of our experts in hand surgery, they inadvertently see CMT, but because it's not the most common reason for these referrals, I think it's fair to say there are very few places where you have people that's all they do. So I think you want to find somebody who knows something about CMT, but mostly I think you just want a good surgeon to counsel you about risks and benefits, because that's another thing. For some of the tendon issues, the surgeries are not that successful. We probably have better success with carpal tunnel release than tendon surgery, which is kind of paradoxical. You would think, the wiring is so much higher fidelity and so much more, but when it's compression of the nerve, we do fairly well. When it's a tendon contracture, like a Dupuytren's, it's a very difficult problem that at least at Mayo, they're very sparing about who they operate on, because a lot of times the surgeries are not that successful. Hope that
So
helps.
I'm kind of stuck then, relying. I mean, they're doing their best, and I'm not saying that they don't seem to know, right? Because I had this surgery about 9 months ago, and they don't know what to do now. They're like, it's made it worse, and they're stuck. They just don't know what to do. And I can't believe that in this day and age that we can't do something.
Well, I think you're illustrating also a very big issue. And the reason we got interested in this topic is it has to do with you missed the first slides, but if you look at disability in CMT, you know, it equals about what people have with a stroke, but it's largely when the hands start getting affected in terms of difficulties with daily living. And so the hands are so important in getting in a relationship with somebody who knows. I mean, I think what I could offer, certainly if you were interested, you could just email me your medical records and I could share it with our colleagues, you know, some of the details. And sometimes a doctor to doctor conversation can help too, because it's kind of the rocket science of hand surgery is when you get neuropathies and other superimposed issues.
Norm,
I
I was just going to say, if you want to email me, I'm the one who sent the Zoom link reminder, Laurel Richardson. You should have my email. Then I can connect you with Dr. Klein.
Oh, that would be awesome. So, I'll email you and ask you a couple questions about how to do that. But that would be so wonderful, doctor, because I mean, it's, again, I'm not trying to complain over Kaiser, but it's obvious they just don't have enough experience in this to move forward.
But I also just want to say that it's just a difficult problem.
Yeah.
And so but I think it's worth another thought or look and just.
Thank you, sir.
Thanks, Norm. Priyanka?
Yeah, hi. I'm Priyanka. I'm sorry, I also joined a little late. I wanted to ask, I have a daughter. She is 7 years old and she has CMT type 2A and hers is kind of severe. Her hands are already pretty affected. So she cannot straighten her hands on her own, but we can still get like passive stretching and she doesn't have contractures yet. And this has happened despite of regular OT. So basically she has like her hands are like this and she can move it this way and thumbs, she can move little bit, but she can't do it. I don't know if you can see this movement is like completely lost. So the only good part I see so far is like she doesn't have contractures, but she's only 7. So my question is, like, you know, in what scenarios do you recommend surgery? I have been looking for hand surgery for last few years. There is very limited information, absolutely close to no information on internet. So I'm so glad that there is someone looking into hand surgeries. But then if there is a severe, we have done nerve conduction on her 2 times so far, but not like extensively. But she does have severe axonal damage. Do you still, I mean, is there still any hope with the surgery that there could be like gain of movement? And also, I understand even if some surgery helps, that could be temporary. And in a couple of years, we might be back to normal, her normal. So my question is basically just even if there is a severe nerve damage, is there still hope with any kind of surgery in hands?
Richard, you want to try? I have some thoughts. So this is a mitofusin 2, MFN2 mutation patient.
That's right.
Is she very weak in her legs too?
Yes, she has absolutely no movement left in her ankles. So her symptoms started around 2 years, like little before 2 years, and she completely lost ankle movement like within just 6 months. It was very rapid movement. First, the CIDP was suspected. We did IVIG infusions for a few months, but that didn't help. And then eventually CMT diagnosis came in. So we didn't expect any clinical improvement. But then her hands were kind of weaker right from the start, but the major loss of movement started happening around age 4, 4.5.
Okay. I just want to make sure that the hands are in proportion to the amount of leg weakness, which it sounds like they are, given how severe she is.
Mm-hmm.
So in children, it's a bit of a different game because you have fewer confounders.
Mm-hmm.
So in older people, they're more likely to get tendonitis, like the contractures, and things like that. But with MFN2, it's unfortunate, but they do really have a primary wiring problem that makes the weakness. And it sounds like that's what I'm hearing from the axonal injury extent that you mentioned with the nerve conduction she's already had. So at this point, you know, I'm not a hand surgeon, but I am not familiar with any surgical approaches that, you know, are available to make that better. And so it is more about the things, taking what you have and making the best of it, and then preventing the contractures, which create their own separate problem.
Yeah.
Sometimes at night, if it's really bad drawing up like this, the kids might wear a splint at night to keep the fingers straight,
Yes.
or at least 8 hours of sleep so they don't get this inordinate shortening of the tendons. And sometimes the real therapies that are best are the sort of things that Josh Burns does with his kids down in Australia, which is physical therapy, occupational therapy, those kind of things. And then when deficits become unsurmountable and, you know, compensation is not possible, then what are the other aids to make the kids productive? You know, and it's in the computer era, sometimes it's, you know, because the keyboards get hard, you know, dragging software, similar things like that, it gets to be quite creative. So there, I think finding a CMT occupational physical therapist can be very helpful, because they kind of been to the rodeo before and they know these problems and what to do to try and help before the kids get, you know, they get down about it, you know, including mom.
Yeah, sounds like then we are doing what we can do. Like we do have splints for nighttime, and we are focusing on adaptations too, like what and how she can do with the limited movement in her fingers.
And this is where the other part, the therapeutics group of the CMTA is so important, trying to stave it off before it gets to that point. You know, that's our mission, right? How do we find a way to keep it from getting there? And that's the big challenge.
Okay,
Thank
thank you,
you.
doctor.
Thanks, Priyanka. Yes, Susan Priest, and you can, you just need to unmute, please.
How's that?
Great.
Okay, my question is, what procedures are the most effective that can be done prior to the need for surgery for carpal tunnel?
So splinting, wrist splinting to prevent excessive flexion of the wrist. Also steroid injection. So sometimes they inject the steroid where the carpal tunnel is close to the nerve. And some patients benefit from that.
Mention about the voice.
Yeah, I have two sons with CM, and my wife have CMT, and
So one thing I just mentioned about Dr. Herman's paper. So they had both splinting and surgery. And if you look at the p-values for success, it's very similar to what we see in other non-neuropathy patients with carpal tunnel, which is that splinting steroids are not as effective as surgery. So in general, I try and get my patients earlier to surgery if they really are having carpal tunnel syndrome, because this is such a critical muscle. You think about the median nerve, which goes through your carpal tunnel, does every flexion, and it provides all the fine motor sensory just in your first 3 fingers. So the median nerve is really the money business of your hand. If your median nerve's working well, you can do most everything. So I think based on our experience and the earlier experience about success with release, you know, I'm waiting lesser times to go to surgery in my patients. Now, occasionally I'll have the case where, oh, the guy was out pulling weeds all day and he got a sort of 3-week exacerbated symptom of carpal tunnel, and I might wait on that. But if it's clearly, you know, 3-6 months and it's classic activity-induced symptoms, as Dr. Champapong nicely outlined, I think it would be probably better in the long road to consider earlier surgery with an expert who knows how to do it well.
okay, my oldest son, that's his hand right now. He had ulnar transformation a few years back and did absolutely nothing.
Yeah, I think that his hand, if everyone can see it, illustrates an important concept. So you can have that kind of flexion at the 4th and 5th, and it's not ulnar neuropathy at the elbow.
Right.
And it has to do with just the natural length of the nerve. So that nerve, because the longest nerves in CMT get affected first is often affected first. So people get a clawing of those two fingers, and it needn't be because of something at the elbow.
Mhm.
So, again, there's getting the diagnosis right with a good clinician who knows about the electrophysiology and or the clinical signs to avoid unnecessary surgeries. I'm not saying his was unnecessary, but I commonly see CMT patients who come in with a hand like that, and I see the scar, and I kind of ask them, well, what led to that? Well, my hand was like that, so the doctor thought I had a compression here.
Mhm.
And I said, well, did you have selective tingling in those two fingers? And or did when you moved your elbow like this, did it cause tingling here? Many times they'll say no. So we're not here to overly, encourage surgery. Again, it's the right place and the right time for our patients.
Yeah, he gets like burning red ants all over his hands, just constant pain on it.
Right. I mean, it could be something else. So for most CMT patients, neuropathic pain is actually fairly uncommon. You can have a tingle here and there, but if it's really burning and painful, sometimes that's not even the tendon. Not even the nerve, it's the tendon. If any of you have ever had tendonitis, it's a terrible burning pain, and I've had it. It can mimic very much neuropathic pain. So again, making sure you're getting the diagnosis right, and sometimes there's more than one thing. So you get tendonitis and that compresses the nerve. So then you have a neuropathic pain. So I think just seeing good people who know about CMT is really important to avoid unnecessary interventions and do the necessary ones.
All right, thank you.
Absolutely. Thank you, Dr. Klein. We had a question come in through the chat, and then I had another one emailed to me. So the question in the chat is, what are the options for laser surgery rather than open surgery? More or less effective than open surgery? Are ultrasound treatments helpful for pain relief?
I'm not acquainted with laser surgery, Dr. Klein.
Yeah, I would say in general, it's not acceptable as a common approach. Something about us Americans, if a knife will work, we look to find a laser, so we love lasers, but I think that the ultrasound guided thread release is probably the least invasive that I know of. And I can give you great stories of guys that, like a mechanic, or a carpenter or a farmer. And then, to do the wrist, historically, they'd have to wait 2 weeks in a splint and then do the other one. They can do both in an afternoon and a Friday afternoon, and they're working on Monday morning. Because it's literally 2 little tiny puncture holes that are probably no bigger than the head of that number 2 pencil. So
Wow.
It's pretty impressive how quickly they can recover. And then they have full visualization during the procedure. So I think it's pretty slick. We don't have a big experience. None of the patients in Dr. Champapong's paper had this ultrasound guided thing, but we know from now looking at lots of CMT with ultrasound, we have no reason to think that it won't have the same great recovery rates that we've seen in all of our other patients, whether diabetics or, laborers, people, get repetitive issues. So I'm very encouraged about this. So in terms of the barrier to going to surgeries, I think they're dropping. I just don't have details about laser surgery. I don't think Mayo's doing it right now.
Okay, thank you. A question that came in through email is asking about the Zancoli procedure and correcting CMT hyperextension. What is sort of the success rate with that Zancoli? I don't even know if I'm saying it correctly, procedure. And if CMT fingers can be straightened manually, is it too soon to consider surgery?
I think that's beyond my pay grade.
Okay.
That's really a very selective hand surgery question.
So Laurel, that was my question. I wasn't
Oh, Anita.
sure.
Okay.
That's kind of a rocket science question.
Okay, so I don't have carpal tunnel syndrome. I've never been diagnosed with that, but this is how both hands were, and that hyperextension, where your fingers go back. The Zancoli was done across here. Zancoli procedure. to prevent that. So now, let me get that right. Where's that camera there?
I can see you.
Yeah. And I also had a tendon transfer to give me motion in my thumb, trying to accomplish pinch grip. And that's pretty much what I got. However, a year later, we went back in because there was a lot of scar tissue preventing movement. And then he went up in this finger to get and remove that scar tissue. And it's way worse. I lost function with the first surgery, and I lost even more function with the second one. So there's parts of me I can't dress on my own anymore. Can't get my braces and shoes on. Yeah, so you can't tell me anything about Zencoli or how common it is.
I can tell you my experience, which is not, it's similar to what you're describing, which is not very successful. So, and I think that the hand anatomy and extension is very complex.
Right.
And in fact, some of the flexors of our hand actually are important in stabilizing this part of your hand so you can get extension. So when I'm a realist, and I am biblical in that I don't like I don't believe in greed. So sometimes, extension is not a big problem. What I'm really trying to help my patients with is flexion.
Right.
Because you can have poor extension and be very functional.
Yeah.
So I'm not in the game of trying to give people a better look, right? It's about, like you were saying, your opposition and flexion. So that's why I think the carpal tunnel release, when you see an 80% success rate, when you see such a common thing, this is to me the home run for our CMT patients. We don't want to be denying them this approach when they have classic carpal tunnel. But for the rest of it, I think it's really on an individual basis and needs to be really thoughtfully considered, because the success rates are far less for tendon surgeries, for a lot of the other surgeries, including even just ulnar decompression in non-CMT patients, is far less successful than CMT, or carpal tunnel surgery.
So if you don't have carpal tunnel syndrome, but you have these other challenges, I can't move that thumb. That's why we were trying to get a pinch grip. Are there other surgeries for CMT then? Because you're saying the tendon transfer I had done is, sometimes successful, and the Zencoli probably shouldn't have been done.
There are surgeries, but it takes really experienced people to know the risks and benefits, and when the risks outweigh the benefits. So, and it's not a trivial event to go through those surgeries. As you can tell the group here, it was probably a pretty big layup for you in terms of being down, with the incisions and everything. So,
right.
I think that we're just not there yet in trying to mechanically overcome some of these barriers, either with strength or tendon issues that can happen.
One last question. I'm in Canada. Are there any recommended CMT specialists in my country?
I know of a really smart neurologist that just moved to Alberta.
Okay.
So he's well trained, and he would do the right thing by you, I think.
Okay, so can I contact Laurel about that? If she gets
his name is Grayson Beecher, Beecher. And if you want to contact me, I can let him know you're looking for a doctor.
Okay.
Yep. So because we're almost at the hour, so let's grab this one last chat comment. It's Linda said, I have had carpal tunnel surgery in my right hand. I also had tendon surgery in my right thumb and right middle finger, as they were both what the doctor called trigger finger. I have the biggest, hardest lump below my middle finger where the surgery was done. It is very sore to touch. Any thoughts?
Why don't I'll let Dr. Champapanga tackle that.
And Linda's holding up her sore. Wow, Linda, I'm sorry about that.
That was actually about 5-6 months ago.
Okay.
And when I really flex my hand as I'm doing, you can see it.
Okay.
Oh, it hurts.
It looks red even.
It
Yeah.
is. I've
Not
got
infected, is it?
CMT type 2, and it has affected my vocal cords also. So excuse my voice.
Oh no. Is it infected? Is there any? So that's where the incision was?
Yep. It is hard as a lump. Is it scar tissue or what?
What should you do, Pitcha? What would you do if you were her?
Also,
I would first start with, did anyone image it to see what is inside?
Interesting point. I was removing stitches after the stitches were removed. So quite possibly, I guess there could be filament still in there that's causing this. Who do I see to determine that? The hand surgeon who did the surgery.
Yes.
Start with that one.
That is also Kaiser.
So I'll just share with you, everyone's comments about tendon surgeries and experiences are mimicking what I see in my practice, which is they are not that successful. And sometimes the best decision is not to do it. And so that's where I think and I do think that people with CMT probably have slightly higher risks for these surgeries. Not because they'd heal any, that they have inherent immunity problems, just because you don't feel as well to have the same protective mechanisms and many things that we take for granted with an intact nervous system. Dr. Champapanga didn't get into the weeds, but all the patients with CMT in that study with carpal tunnel, none of them had the median sensory response left. And that sensory response helps guide you protecting your hand just for little micro traumas and things. So surgical repair, surgical recovery, those kind of things may be delayed. And you have to be even more conscious of the wound after surgery, because you could put it in somewhere and you wouldn't know, oh, I'm hurting it. So you have to be even more careful.
Yeah. Thank you, Dr. Klein, and thank you, Dr. Champupong, for being with us tonight and for sharing your time and your talents in this wonderful paper with us. I think that even if the results are not 100% what we want to hear, we know we're headed in the right direction with this kind of study, with this kind of work and these kind of trials. So thank you for sharing the results with us and for all of your dedication to the work that you do in neuromuscular disease, especially CMT. So thank you for being with us. And